So my second talk actually was supposed to be given by Dr. Celia Chan, but she couldn't make it. So I'm going to fill in for Dr. Celia, and I would like to acknowledge help from my mentor, our mentor, mine and Ambika's mentor, Dr. Naveen Jaykumar. I based my talk on his talk. So as Rohit was mentioning, any diplopia, the first question that you'll ask is diplopia monocular or binocular? If diplopia disappears when one of the eyes is closed, it's a binocular diplopia. You're looking at asymmetrical ocular motility. If the diplopia persists even if the eye is closed, you're looking at some ocular cause. Now, when we're talking about vertical diplopia, uh, you need to ask for these three questions apart from that diplopia questionnaire. Were there any previous eye surgeries? Because sometimes an eye surgery with asymmetrical fibrosis can have a vertical diplopia. Was there any trauma to the head or the orbit? And associated CNS features. The first thing you look at when you have a patient with vertical diplopia is what is the head position. What is important for us for this talk is there any head tilt? And is there any chin up or chin down position? Because both of those would tell you that patient has a torsional diplopia with a compensation with a head tilt or a chin up and a chin down position. The motility examination would involve ductions, versions, and cover test. An additional test which will help you would be a Maddox rod test. Normally when you place a Maddox rod in front of one eye, you'll find, so if you place it vertically, it will create a horizontal line, and you'll find that the horizontal line is aligned with the dot. And whenever the eye is elevated, the image goes down. When the eye is depressed, the image goes up. So for example, if patient has right hypertropia, you place the Maddox rod in front of the right eye, you'll find the line which is produced by the Maddox rod is down. So that's number one. The other 2 points to remember, you are looking at the elevators and depressors. So when a patient, for example, in this example, when the patient is looking to the left eye is abducting, right eye is adducting. So what muscles are acting? When the patient is looking to the left, the abduction is brought about by superior rectus and inferior rectus, and the adduction, the superior oblique and inferior oblique are working. And the another important point about the intorsion and extorsion, remember superiors are intorters. So keeping that in mind, let's look at a couple of examples of patient with vertical diplopia. Oh, I'm sorry. So I'll show you those example. The screen is gone. So I have basically two videos, one showing the superior oblique palsy, where I wanted to show you the three-step test, which will tell you how to do three-step test and how do we really come to a conclusion. So three-step test, the first thing is you notice, first thing to observe is which eye is higher. So which eye is hypertropic? The second step is what happens to the hypertropia when the patient looks to the right and to the left. And the third step is what happens to the patient. And third step is what happens to hypertropia when the patient tilts his head to the right and to the left. So let's take an example of right superior oblique palsy. Superior oblique is a depressor. So in a right superior oblique palsy, when the patient looks straight, the right eye would be higher. So there is a right hypertropia in most instances. Now the second step in a three-step test is what happens to this when the patient looks to the right and to the left. Right eye is higher. In a superior oblique palsy, when the patient looks to the left, the inferior oblique, which is acting, will take the eye higher, while superior oblique, which is supposed to negate the action of inferior oblique, is not working. So when the patient looks to the left, the hypertropia will increase. And third step is the head tilt. So when the patient tilts the head towards the right side itself, when you tilt the head to the right side, the left eye is supposed to extort, right eye is supposed to intort. Superiors are intorters, superior oblique is not intorting, so the eye will go up. So here is a patient who has a hypertropia which is more on the right side. If it's a superior oblique palsy, the hypertropia will increase when the patient looks to the left. and hypertropia will increase when the patient tilts the head to the
While we're
All right,
working
I
out.
think there is anyway, it doesn't matter. So these are the 3 steps that you follow when the patient has a hypertropia. So they which eye is higher, what happens when the patient looks to the right and left, and what happens when the patient tilts to the head to the one side or the other side. Now there is another feature which will help you to determine what's going on. And that is you look at the fundus. Now superior oblique, let's say we are taking an example of superior oblique palsy. Superior oblique is an intorter. If the superior oblique is not functioning, the eye would have gone into excycloversion. So when you look at the fundus, you'll find that the optic disc is higher and macula has gone down. So that's something which again will give you a clue as to what's going on. So that's one important cause of vertical diplopia, a fourth nerve palsy. The other cause, which Rohit partly mentioned, is a restrictive myopathy like thyroid ophthalmopathy or a patient having, let's say, blowout fracture. So here is an image which tells you that this is a fundus examination of left superior oblique palsy, where you find that there is macula which is down than the optic nerve. So that's something which you can look at. What about bilateral fourth nerve palsy? Again, patient can have a vertical diplopia, but here there will be right hypertropia in the left gaze and left hypertropia which increases in the right gaze. Patient can have a small hyperdeviation primary gaze if there is an asymmetrical palsy. Patient would have a large excyclotropia with a V pattern esotropia. I'm sorry for the video. Now this is the second video was about left inferior rectus palsy. I had a video of performing the Belchowski's or Marshall-Park's 3-step test in patient with left inferior oblique palsy, where it would have behaved differently. So in a superior oblique palsy, you'll find that hypertropia is more when the higher eye is adducting. In this patient with a left inferior rectus palsy, because inferior rectus works when the eye is abducted, you would have found that the hypertropia was more when the higher eye was abducting. And this was a patient who had floor CT, and this is CT orbit, where you find there is a fracture orbital floor. So other cause, so that's about the superior oblique palsy or a blowout fracture. Other cause can be a supranuclear cause, which is not very common for us to see in an ophthalmic OPD, which is a skew deviation, where there is a vertical misalignment, which can be constant or transient, and patient can also have double vision. In patient with skew deviation, you will have hypertropia always present in primary position. However, the differentiator between a superior oblique palsy and a skew deviation is looking at the fundus. In skew deviation, the higher eye would be intorted, which is in contrast to superior oblique palsy, where the higher eye would be extorted. Apart from that, you will find that there is a binocular tilt of subjective visual vertical, while in a superior oblique palsy, there will be a monocular tilt. One of the tests which is often described in a skew deviation is you make the patient lie down in a supine position. You will find that the hypertropia decreases. Skew deviation is because of supranuclear problem. It can happen in somebody who has, let's say, a medulla problem. Now these are the other rare causes of vertical diplopia, like hemifield slide phenomena, which is often seen in somebody who has a chiasmal compression. In a chiasmal compression, you have bitemporal hemianopia. So in other words, the retinal correspondence is lost. So any patient who had that mild phoria would become apparent, and that is called hemifield slide phenomena, where especially a vertical phoria gets manifest and patient complains of vertical diplopia. The other important features is foveal displacement syndrome, or very rarely a non-organic cause of vertical diplopia. So we covered ptosis and diplopia, where we spoke about myasthenia, and as I said, myasthenia would be in differential of any patient who has an acquired ptosis or even acquired diplopia. Patient can present with vertical diplopia in myasthenia or thyroid as well. Thank you. I'm sorry for the video.
We keep up the applause and for Rashmin having done his level best with adverse IT circumstances. And I think the important point that he was trying to make was that when you're doing the Bilchowski test, it is common to think of it as a test for a fourth nerve palsy. It is not a test for a fourth nerve palsy per se, but the test for to to isolate the vertical, cyclovertical muscle that's involved in a vertical diplopia. Do you want to take some questions now, Rashmin? Or
We'll do it later.
Okay,